All right, so the hypothalamus is connected, we said, to the pituitary gland by two networks. One is a vascular network that carries the hypothalamic releasing hormones directly into the anterior pituitary gland. And then the second is what they call a neurological network, and that delivers the other two hypothalamic hormones, that antidiuretic hormone, that ADH, and the oxytocin, also to the posterior pituitary so that it can be stored. When the body needs the hormones, then the hypothalamus stimulates their release. So we have a couple different lobes in the pituitary gland. So we have your anterior lobe. The anterior lobe produces 6 major hormones, we're going to talk about them, that are needed for the regulation of growth, reproduction, and some metabolic processes. So the pituitary gland is actually located, it's in our skull under that layer of the dura mater, if you guys remember back to biology. And then it has 3 lobes. So we said the anterior, the posterior is going to store those hormones, that ADH and that oxytocin. And then the intermediate lobe is going to produce endorphins and enkephalins. These are released in response to the body when it's under severe stress or pain. They work by occupying specific endorphin receptor sites in the brain stem of the brain to help block that perception of pain. So those major hormones, those 6 major hormones that we were talking about that are produced by the anterior lobe is the growth hormone, the androcorticotropic hormone, the follicle stimulating hormone, the luteinizing hormone, the prolactin hormone, thyroid stimulating hormone. We also call it THS or thyrotropin. You'll see those terms used interchangeably. So anytime there's a deficiency or an overproduction of these hormones, this disrupts that regulation process. So 2 of the anterior pituitary hormones do not have a target organ to produce hormones. So they cannot be regulated by that same type of feedback mechanism that we were just talking about. That's the GH and the PRL, the growth hormone and the prolactin. The hypothalamus responds directly to the rising levels of these 2 hormones. And when the levels begin to rise, the hypothalamus releases the inhibiting factors, somatostatin and PIF, directly to inhibit the pituitary's release of these 2 hormones, the growth hormone and the prolactin. The hypothalamus and the pituitary work together to help maintain that endocrine activity that we've been talking about. We call that endocrine activity inside the body. It all occurs upon this specific axis. It's the hypothalamic pituitary axis, or HPA. This system uses a number of negative feedback systems. So the hypothalamus secretes releasing factors that are going to cause that anterior pituitary to release stimulating hormones. The hormones will act with specific endocrine glands to cause the release of hormones or stimulate those cells directly. The stimulation shuts down the production of the releasing factors, and then in turn, this leads to decreased stimulating factors and decreased hormone release. So this is just a slide for your the negative feedback system and how it works. It works it's called the negative feedback loop. It works very similar to what you would think about like supply and demand. Increased output from the system inhibits the future production by the system. So basically the system controls how much product it makes by shutting down certain manufacturing of that hormone when levels of output or the amount of accumulated product that we have stored in the body gets too high. The hypothalamus senses a need for a particular hormone. So this is an example of this negative feedback. It senses a need for a particular hormone. It secretes the releasing factor directly into the anterior pituitary. In response, the anterior pituitary then secretes that hormone. In turn, that hormone is going to stimulate the gland, and then the hypothalamus will sense increases for a particular hormone and send messages to the anterior pituitary to stop producing the hormone. So we also have other hormones that are released in response to certain stimuli in the body. So the pancreas produces and releases insulin, glucagon, and somatostatin. The parathyroid glands are responsible for releasing parathyroid hormone, parathormone in response to calcium levels in the immediate region. We have the juxtamugular cells in the kidneys, which release erythropoietin and renin in response to a decrease in pressure or decreased oxygenation of the blood that's going through that glomerulus. We have GI hormones that are released in response to local stimuli in areas of our GI tract. So that would be certain acids, proteins, or calcium. The thyroid gland produces and secretes other hormones called calcitonin. That's going to come in direct response to serum calcium levels in our body. Prostaglandins are released throughout the body in response to local stimuli in the tissues that produce them. We have activation of the sympathetic nervous system, which is going to directly cause the release of that ACTH and the adrenocorticoid hormones to prepare that body for that fight or flight. And then we have aldosterone, which is an adrenocorticoid hormone, which is going to be released in response to the ACTH, but it is also directly released in response to our body having high potassium levels. All right, so hypothalamic and pituitary agents. Oops. All right, so the endocrine system's main function, like we said in the beginning, is to maintain homeostasis throughout the body by releasing a number of different hormones. The hypothalamus produces releasing and inhibiting hormones, which stop and start the production of all the other hormones throughout the body. Our hypothalamus plays a very important role in the endocrine system. Glandular activities in the endocrine system are either going to stimulate or suppress those release of hormones. If there's too much or too little glandular activity in the body's homeostasis, it will become disrupted. When it's disrupted, it can lead to a number of different disorders and interfering with that normal functioning of the endocrine glands. So we have hypothalamic releasing hormones that have with diagnostic functions, which means they can be used to diagnose certain conditions. So the hypothalamus is going to produce those releasing and inhibiting hormones, which is going to start and stop the production of all the other hormones. Factors that stimulate the release of hormones are corticotropin releasing hormones. The hypothalamus releases these hormones, which cause the release of corticotropin, which is also called ACTH, from the anterior pituitary. The ACTH stimulates the adrenal cortex to produce and release corticosteroids. Increasing levels of corticosteroids inhibit the release of ACTH. So Cushing's disease is a result of excessive secretion of the adrenocorticotropic hormone. This is something that some people suffer from. So you can use this hormone, this releasing factor, to help diagnose your patient with Cushing's disease. Then we have gonadotropin, which is the medication name would be Factrol. So this checks the anterior pituitary response for a deficiency. Gonadorolin is a man-made protein that is like a hormone in the body called the gonadotropin-releasing hormone. The gonadotropin-releasing hormone causes the pituitary gland to release other hormones in the body, including the luteinizing hormone and the follicle-stimulating hormone. Gonadorolin is used to test how well the hypothalamus and the pituitary glands are working. All right, when the hypothalamus senses a need for a particular thyroid hormone, it secretes the releasing hormone or factor, TRH, or protyroglin, directly into the anterior pituitary. In response to the TRH, the anterior pituitary secretes TSH, which in turn is going to stimulate the thyroid gland to produce the thyroid hormone. When the hypothalamus senses the rising level of thyroid hormone, it stops secreting that TRH and then is going to result in a decreased production of that TSH. Then we also have the GHRH, which is growth hormone releasing hormone. Also known as ceramolin, that's what we can use to test people. It's a man-made hormone. It stimulates the production of the growth hormone by the anterior pituitary. Then we have Cozarelin or Zoladex, which is an analog of the GnRH. It inhibits the pituitary gonadotropin secretion with a resultant drop in the production of the sex hormones. Then we have Hysterelin. There's a couple different brands here. They are GnRH agonists. They inhibit the gonadotropin secretion and they decrease the levels of steroid sex hormones. All right, so these are the hypothalamic releasing factors that are used to treat diseases and their actions. So we have Lupron, which occupies the pituitary GnRH, which is that gonadotropin releasing hormone receptor sites, so that they no longer respond to the GnRH. Then we have the Nafarelin or the Cineril, which is a potent agonist of the GnRH, and this works to decrease the production of the gonadotropins by repeated stimulation of those receptor sites. And this is a good slide. It just shows you the site of action of the hypothalamic and the pituitary agents, where they work, and what they're going to do inside the body. All right, so the anterior pituitary hormones and their indications. So somatriptan there's a couple different medications here. We're going to talk in depth about somatriptan. It's one of the ones that we see most. So Corax is one that you can use for hypogonadism, ovulation, prepubertal cryptothyroidism. We have corticotropin, or ACTH, which is used to test the adrenal function and the responsiveness. We have conzotriptan, which is used to diagnose adrenal dysfunction. We have menotropins, which is a fertility drug. And then we have somatriptan, which we use to diagnose Turner syndrome, patients with AIDS, growth hormone deficiencies, growth failures. So somatriptan is a hormone of recombinant DNA origin that is equivalent to the human growth hormone that we find inside the body. The indications, we would use this, like we said, in patients who are experiencing growth failure, any kind of growth hormone deficiency, Turner syndrome. So Turner syndrome is a condition that usually only affects females. It results when one of the X chromosomes, which is one of the sex chromosomes, is missing or partially missing. It can cause a variety of different medical and developmental problems. Some of the things we see are shortened height, failure of those ovaries to develop, and sometimes you can see heart defects. The pharmacokinetics of this medication, it is injected and it reaches its peak in about 7 hours. It's widely distributed throughout the body and it's excreted through the urine and the feces. So we're going to want to watch our patients that have kidney issues. Any contradiction to this medicine, well, you wouldn't want to take it if you have a known allergy because it could cause a hypersensitivity. Any allergic reactions to any of the ingredients in the drugs. And then you need to be careful with using this in the presence of closed epiphyses. So this is when the bones close. This can cause a problem with the bones. And then in patients that have any underlying cranial lesions. Adverse reactions that we see, sometimes we have inflammation around that injection site. It can cause inflammation other areas in the body, so you might see some swelling and joint pain. And then it can cause hypothyroidism and insulin resistance. So we have, we talked about the somatriptan. There's another one. So the one we talked about on the previous page was just somatriptan. This is somatriptan, which is an rDNA origin. Another brand name for it is Zorbativ. We use this to help treat short bowel syndrome. Then we have thyrotropin, which is a diagnostic agent that we use to diagnose thyroid function issues in certain patients. And then we have somatrim or protropin, which is used to treat children with growth failure. All right, so we have growth hormone antagonists. So these medications are going to be your bromocriptine, mesylate, you have lanreotide, octreotide acetate, and pegvisomant. So what do these do? So their actions, they are an inhibitory factor released from the hypothalamus. They are not used to decrease growth hormone. And it has multiple effects on many of those secretory systems that secrete those hormones. We use these medications to treat acromegaly. The pharmacokinetics of this is going to depend upon the drug. We're not going to talk about any of these in specific, but they all vary according to what type of medicine you're talking about. Contradiction would be any known allergy to any of the ingredients. All of these have to be used cautiously in patients who are pregnant and then patients who are lactating, because it does go into the milk, to the breast milk. You would want to use cautiously if the patient was suffering from any other endocrine disorders. And then the adverse reactions are going to vary with each medication. But these are the growth hormone antagonists. Then we have the posterior pituitary hormones. So that's convapatin, desmopressin, and tolvapatin. So we are going to talk mainly about desmopressin because that is the one that we use the most, and your book goes into detail about that one. So we would use this for the treatment of neurogenic diabetes insipidus. So diabetes insipidus is when the body produces a large amount of dilute urine, which doesn't have any glucose in it. The blood becomes concentrated and the blood glucose levels are higher than normal. Your patients are going to present with what we call polyuria, which is lots and lots of urine. They're just going to keep telling you, I have to pee, I'm peeing so much. Polydipsia, which means that they're extremely thirsty, and then dehydration. So this is a metabolic disorder. where basically they produce large quantities of this dilute urine and they're constantly thirsty. This is caused when the patient has a deficiency in the amount of the posterior pituitary ADH. So we would give them desmopressin for this. We also use this to treat patients that have hemophilia A. Hemophilia A is a clotting factor disorder, which causes the patients to be at risk for increased bleeding. It messes with their ability to be able to clot properly. And then we also give it to patients that have von Willebrand's disease, which is also another bleeding disorder. And then nocturnal enuresis, we would give it to them as well. So pharmacokinetics, it is rapidly absorbed and metabolized. It's excreted in the liver and the kidneys. So we're going to want to watch out for those patients that have kidney issues and liver issues. And then we don't want to use this in patients that are pregnant because it can cause uterine contractions. Contradictions, we would not want to use if they have a known allergy. And then also we would not want to use in patients that have severe renal dysfunction. So this is a little bit harder on the kidneys than it is on the liver. You want to use cautiously if any known vascular disease because of the effect that it has on the smooth muscle. In patients that suffer from epilepsy and asthma, this medication can exacerbate their condition. So you want to use cautiously with those individuals. And then we also want to be careful if they're pregnant or they're lactating, use cautiously. Some adverse reactions that we see. So sometimes there's a huge shift in water retention throughout the body. So it can actually cause water intoxication to the patient. So you want to closely monitor their labs and their electrolytes. It can cause stimulation of the GI tract, which can cause a whole bunch of issues. Some people say that it causes local nasal irritation, and then sometimes people just get a hypersensitivity from it. All right, so adrenocortical agents. So what are they used for? We use them to suppress the immune system. They are used for short-term use to relieve inflammation during acute stages of illness. They do not cure any inflammatory disorders. They just help to minimize or relieve some of that inflammation, but it's not going to completely get rid of whatever the issue is. So this is a slide in your book that just shows you the controls and the actions of the adrenal glands. This next slide is going to show you the site where it starts in the hypothalamus through the anterior pituitary into the adrenal gland. You guys can take a look at that. So what types of corticosteroids do we have? We have androgens. So there's three altogether. Androgens, glucocorticoids, and mineralocorticoids. So the androgens are your male and female sex hormones. Your glucocorticoids are to work to stimulate an increase in glucose levels so that our body has energy. And then our mineralocorticoids affect our electrolyte levels and our homeostasis. All right, so what are causes of an adrenal insufficiency? So adrenal insufficiency, also sometimes you'll hear it in the clinical setting as an adrenal crisis. This occurs when a patient does not produce enough of that ACTH hormone. The adrenal glands are not able to respond to the ACTH. The adrenal gland could be damaged. It could happen secondary to surgical removal of the gland. So obviously, if we remove that gland, it's not going to be able to make that, that hormone anymore. Sometimes it happens when the patient has been subjected to prolonged use of corticosteroid hormones. So what happens is when we use these exogenous corticoids, they actually work against that negative feedback system, and they kind of put that negative feedback that feedback system on pause. The adrenal glands actually start to atrophy because they haven't been using and producing that hormone. So when we are giving patients steroids in the hospital setting, to prevent this from happening, we always want to recommend that they only stay on the steroids for the shortest term needed, and that when we do take them off of it, that we're going to wean them slowly from the hormones. So that way the adrenal glands have time to recover and they can actually start producing those hormones again. So I don't know if you've ever taken steroids before, but usually you'll take them for a certain number of days and then you'll start weaning off of them. So maybe you started out with 2 tablets for 5 days, and then on the 6th day, you'll take 1.5 tablets for 2 days, and then you'll go down to 1 tablet and then down to half tablet. So it's very, very important that when you're educating your patients that you're telling them that they have to make sure that they're weaning themselves off. Follow their discharge rules because it'll always be outlined in their paperwork. Patients who have adrenal insufficiency may do quite well and not even realize that they have an issue until they become, till they encounter periods of stress. It could just be regular stress in their life. It could be something like a motor vehicle accident. Maybe their body underwent some kind of trauma or a surgical procedure or even some type of massive infection in the body. Because they're not able to supplement the energy consuming effects of that sympathetic reaction, then they enter into that adrenal crisis. This can cause physiological exhaustion on the body. It can cause them to have hypotension. Sometimes we might see a fluid shift. That could also lead to shock, and then eventually it could even lead to death if it's a serious condition. So how do we treat these patients? Patients in adrenal crisis are treated with a massive infusion of replacement steroids. They do require constantly monitoring. Usually they're in the ICUs, and sometimes they have to go on life support until they get past the hump and they're kind of out of the woods. So what kind of signs? We already said the signs. Yep, and the treatment. All right. So our glucocorticoids, we have our hydrocortisone, our cortisone, prednisone, and trimethylone. So these work to enter the target cells and they bind to what we call cytoplasmic receptors. They initiate one of many different complex reactions that are responsible for immunosuppressant effects in the body and then anti-inflammatory responses in the body. They're indicated for short-term treatment of all kinds of different inflammatory disorders. We give these to help relieve discomfort associated with these anti-inflammatory disorders. And to give the body a chance to heal from the effects of inflammation. So we talked a couple weeks ago about inflammation, how our immune system and inflammation works and goes to the site of any type of injury. And we recognized from that learning that inflammation is a good thing, but sometimes too much inflammation in the body, even though it's doing its job, can have the adverse effect and can be harmful. So that's when we have to use these medications. So these medications are well absorbed from many different sites. Most of them are metabolized within the liver and they're excreted in the urine. So we're going to want to watch their liver enzymes, their urine, their kidney enzymes. We're also going to want to monitor their blood sugars. So it's very common for you to see patients that have been in the hospital with a more advanced illness that have had to have these higher level of steroids, that they have to go on insulin for a small period of time, even if they're not a diabetic, because when we give them these steroids, it increases their blood sugar. Even if you're just giving them a small dose of medications, and maybe you have, I see it all the time where patients aren't diabetics to the point where they take insulin. Maybe they just control it with an oral medication, but then they come in the hospital and they're on these steroids. And then when we test their blood sugar, they're like, oh my God, what's wrong with my blood sugar? It's so high, I'm really worried. So you just want to make sure that you educate them and let them know that it is normal, that it is in response to the steroids, and that once they stop the medication, their blood sugars should go back to the way they used to be before. So contraindications for giving these medications. We would not want to give if you have a known allergy, obviously. We also want to use very cautiously in patients that have an acute infection, because sometimes it could become serious or fatal if we block those immune and inflammatory responses, right? So we talked and said that inflammatory responses are good. They help our body. Well, if we give them steroids and we're trying to stop that process and then they get an infection, well, then that would have the complete adverse effect. So that's why we have to use very cautiously in patients who have or develop an acute infection. And then you want to use carefully with patients who are lactating, because those anti-inflammatory and immunosuppressive actions could be passed on to the baby. We want to use caution with patients that have diabetes, because those, remember we said it elevates the glucose level and it can disrupt their glucose control. We also want to use this medication cautiously in patients who have peptic ulcers, so ulcers of the in the belly, because steroid use is associated with the development of ulcers. So that's another thing you want to educate your patient about. They might want to start like not a probiotic, pantoprazole or some type of acid relief while they're taking steroids, because they could develop an ulcer. Some adverse effects that we see from these. So sometimes if they're used locally, you might have local inflammation. Sometimes patients report burning and stinging. Drug-to-drug interactions, we want to, so if you have a patient that is on steroids and they're taking erythromycin, which is another antibiotic, ketoconazole, and these are in your book, or terlindomycin, this can cause an increase in toxicity when you use steroids in combination with any of these medications. So you would just want to monitor the patient closely. And then we notice a decrease in the effectiveness of the drugs when we give with salicylates, certain barbiturates, or rifampin. And we're going to learn so much more about all this when we get to Concepts 1. This is kind of just like a little brief overview. So the thyroid and the parathyroid agents. So your thyroid gland sits right here, right over top your trachea. Sometimes if you are doing your physical assessment and you are examining the lymph nodes here, sometimes if you come around and a patient has an enlarged lymph node, you can feel it, not lymph node, thyroid gland, you can feel it. Sometimes thyroid glands get little tumors, sometimes they're benign, sometimes they're cancerous, sometimes you can see them through the neck. So if you see anything that when you're doing your physical assessment that looks off, you can always kind of palpate there. Sometimes if you come when I go to my clinicals as a nurse practitioner, it's always helpful for me if I stand behind the patient and then reach my arm around and kind of feel like this, and then you can get a better grip on it and you can feel it. You can certainly do that to see if it feels like it's swollen or if you feel any nodules on there. So that's the thyroid gland. And then on the back of the thyroid gland are these 4 little circles. These are your parathyroid glands. So the thyroid is going to control, we said, certain levels, hormone levels. It's going to, hypothalamus is going to tell that pituitary gland to secrete TSH, which is going to make the thyroid gland secrete that T3 and T4. So when we get into Concepts 1, you guys are going to have to determine these certain levels, which, you guys are going to have questions about which one of these hormones is not working. Which one would you, if the TRH is doing blah, 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 then you would have to tell me what kind of levels do you think you would see with the T3 or the T4. So it's going to get a lot more complicated. I bet you guys never thought you'd have to see that again after you went to biology. Here it is again. Okay, so these two, the thyroid and the parathyroid, are also responsible for controlling our calcium levels in the body. So this slide is in your book. You can take a look at that. So what types of thyroid dysfunction do we see? So you'll see these very commonly in the clinical setting with your patients. Most of the ones that I see are hypothyroidism. So you have hypothyroidism, which is underactivity of that thyroid gland, so it doesn't produce enough hormones. And then you have hyperthyroidism, which is overactivity, so it's producing too many hormones. So patients can develop hypothyroidism for a for various amounts of reasons. You can have absence of the thyroid gland, so maybe they had a tumor and it was removed. You could have lack of sufficient iodine in your diet, which is needed to produce certain thyroid hormones. You could have lack of sufficient functioning of surrounding thyroid tissue. This could come from certain autoimmune disorders or any kind of tumor. And then you could have a lack of TRH, which is going to be related to also a tumor or any kind of disorder in the hypothalamus. So we said that you could have a lack of sufficient iodine in the diet, which we need to help produce this thyroid hormone. So we would want to tell our patients to increase, if we were doing education, we would tell them to increase iodine in their diet. So certain vegetables, you can increase your vegetables intake because you're living a healthier lifestyle. So vegetables will help. You can use iodized salts because they have iodine in it. Then we have hyperthyroidism, which we said is excessive amounts of the thyroid hormone that are released into the circulation. So you will see patients that have too much. Sometimes they get what's called Graves' disease. You'll learn a lot more about that next semester. Signs and symptoms. So when you see a patient that has hyperthyroidism, they're going to have an increase in their body temperature. Okay. They are going to have, sometimes they're going to present with tachycardia. They might present with thinner skin. We expect to see that sometimes in our older adults, but if they have hyperthyroidism, we'll see it in our younger adults. They might complain of heart palpitations. They might come with hypertension, so an increase in blood pressure. They might have flushing where their face gets red often. They're going to complain of an intolerance to heat. They might have amenorrhea, which is a dysfunction with menstrual cycles, and they might exhibit weight loss and even have a goiter. So some people, there was a time when people were being prescribed this medication for weight loss because basically hyperthyroidism is is when your metabolism is just too high. So obviously when your metabolism is too high, it results in weight loss. So there was a period of time where medications were being abused for that reason, which is obviously something we don't ever want to do. So if your patient ever brings that up, make sure you educate them and tell them that that's not safe to do. You strongly are against that. Okay, so for hyperthyroidism, so we give certain medications to treat hypothyroidism. So this could be your thiamides. These prevent the formation of thyroid hormone within the thyroid cells. This causes a lowering of the serum level of thyroid hormone, and it partially inhibits the conversion of T4 to T3. Again, we would indicate this medication for hyperthyroidism. It is well absorbed from the GI tract, and then it is concentrated in the thyroid gland. Some excretion can be detected in the urine. You wouldn't want to use if you were pregnant. Some people do use it when they're pregnant. They just have to use it very cautiously. And then you wouldn't want to use if there's any known allergy. You would want to use cautiously in parents, moms who are lactating, because it can go into the breast milk. And then adverse effects. So whenever you have these hyper and hypo situations where you're trying to solve one issue, sometimes we inadvertently cause another issue. So with the example of blood pressure, patients that have high blood pressure, we give them blood pressure medicine, while sometimes we cause low blood pressure. Well, this is the same thing with the hormones in the body. We always run the risk of causing the opposite to occur. When the doctors prescribe these medications, they don't know. They start off with the most common dose, but sometimes that dose is too much for patients. So that's why they spend a lot of time going back and forth to the doctor when they're first diagnosed until they get their doses exactly where they need to be. So if we gave too much of this medication, then we could cause a thyroid suppression, and then they could be suffering from hypothyroidism. So drug-to-drug interactions, we want to use cautiously with oral anticoagulants. They deem them not as effective sometimes. We want to use cautiously with metoprolol. We give that medicine for the heart, theophylline, propranolol, and digitalis. So those will cause this medication to not be as effective. So we just want to use cautiously. All right, so we can also treat with iodine solutions. Oops. We said that sometimes patients have, they don't have enough iodine in their body, so it can cause the thyroid cells to become oversaturated with iodine and stop producing the thyroid hormone. So if they didn't have enough iodine, it would be hypothyroidism. If they have too much, it would be hyperthyroidism. So sometimes we see this in patients who have any kind of pre-surgical suppression of that thyroid gland and acute thyrotoxosis. So these medications are absorbed from the GI tract, and they're very well distributed throughout the body. They are excreted in the urine, so we're going to want to monitor their kidney function. We're going to use cautiously in patients who are pregnant, and then patients who have pulmonary edema or pulmonary tuberculosis. It can exacerbate their symptoms. Adverse effects, so hypothyroidism, right? Because if we give them too much, they might say that they have a metallic taste and a burning in their mouth. That comes from the iodine and the medications. And then some people complain of sore gums. They say that their teeth hurt, diarrhea, stomach upset, skin rash, and then stained teeth. And then drug-to-drug interactions, the anticoagulants, the theophylline, the digoxin, the metoprolol, and the propranolol, because they might decrease the effectiveness. So replacement hormones that you may see in the clinical setting for treating hypothyroidism. So the one that I see the most is levothyroxine or Synthroid. Those two names are used interchangeably. I have seen Levothyroid once or twice, not often. The gold standard is Synthroid or levothyroxine. They also do thyroid desiccated, these actually come from animal thyroids that have been dried out, and they contain T3 and T4. We have Cytomel, which is a synthetic salt of T3, and then we have Lyotrix, which is also a synthetic preparation of T4 and T3 in a standard ratio of 4:1. But the one that you guys are probably going to see the most is levothyroxine. So parathyroid dysfunction. So the parathyroid is on the back of the thyroid gland, 2 on each side. So with the parathyroid, patients run the risk of developing hypoparathyroidism or hyperparathyroidism. Hypoparathyroidism is the absence of the parathormone most likely to occur with accidental removal of the parathyroid glands during thyroid surgery. So if we remove those glands, they can't make any of the parathyroid hormone. And then the hyperparathyroidism is when the parathyroid produces an excessive amount of that hormone. And this can occur as a result of sometimes if they have a parathyroid tumor or if they have certain genetic disorders. So agents to control blood glucose levels. This is important. You are always going to have to deal with patients that have blood glucose issues. I feel like every day you're going to have patients that you're giving insulin to. Again, this is a brief overview. We're going to go into a lot more of this information when we get into metabolism. So what is the function of our pancreas gland? So we have the endocrine gland, which that produces hormones in the islets of Langerhans, if you guys remember that from biology or anatomy and physiology. And then we have the exocrine gland, which releases sodium bicarbonate and certain pancreatic enzymes directly into that common bile duct that is then released into the small intestine. This helps neutralize the acid from the stomach, and it helps aid in digestion. So we have insulin. Insulin is a hormone that is produced by those beta cells that are located in the islets of Langerhans. What is their job? They are reduced into the circulation when the levels of our glucose around these cells begins to rise. So when we eat food that has sugar in it, those hormones secrete the insulin. It stimulates the synthesis of glycogen, the conversion of lipids into fat, which is stored in the form of adipose tissue, and then the synthesis of needed proteins from amino acids. So what is the classification of diabetes mellitus? So we have two different types. We have type 1, which is insulin-dependent diabetes mellitus. So this usually occurs as a very rapid onset. It typically is seen in younger people. Usually that's when they are diagnosed with this, when they're children. It's connected in many cases to viral destruction of the beta cells of the pancreas. So they don't make any insulin at all, okay? Then we have type 2, which is non-insulin dependent diabetes mellitus. So this usually occurs in mature adults. It does have a slow and a progressive onset, and it is usually caused by certain risk factors. So patients that we see that get diabetes type 2 are patients that are obese, patients that lead very sedentary lifestyles, patients that do not eat properly. So they're eating high fatty foods, high sugar foods, no fruits, no vegetables. They don't have a good diet. So this is something they can develop it as they're older, but then they can also work, and hopefully in most cases, they don't have to be on insulin, so they can lose weight. I've seen patients that have been on insulin. I have a couple friends who have been on insulin 3-4 times a day that lost weight, changed their diet, started exercising, and now they're not on anything anymore. So it is something that can be reversible. Medication can help. We always start out with oral hypoglycemics first. And then if they do not help the patient, then we work our way up to insulin. But we want them to have those lifestyle changes. So in the primary care setting, not so much in the hospital, is where you're going to see this push for, you know, this is where you're at right now. Your blood sugar looks like this. I want you to start modifying your diet. And then they come back in a few months and they haven't done that. Things are getting worse. So then they might give them a PO pill, but you're still encouraging them to make these risk factor changes so that they don't have to stay on this medication. Because diabetes is a very debilitating disease. We're going to learn a lot more about it. It can cause you to go blind. It can cause you to get your limbs cut off. It's really scary, and it's very, very debilitating. So this is the site of action for the drugs that we use to treat diabetes. You can take a look at this chart. It is in your book. All right, so we said that we treat patients high blood sugar, sometimes with insulin. So just a little background, when patients come into the hospital, and a good percentage of patients that come in that have diabetes don't take insulin because it's not severe enough, but they take oral hypoglycemics. Well, when they come into the hospital, a lot of the medications that they take interfere with some of the things that we would do in the hospital. For example, a lot of patients, like the gold standard oral pill to give patients that have diabetes is metformin. So if you come into the ER and you got something going on and you have to go to a CT scan, if you have taken your metformin that morning and then you get contrast, the combination of those two can completely shut your kidneys down, like kidney failure, like you need a transplant. It's very dangerous. So typically hospitals have protocols where when you come into the hospital, we stop all of your oral hypoglycemics and we put you on insulin, even if you don't take insulin at home, because we don't know what they've taken and we don't want to have any issues, obviously. But they don't do a really good job of explaining that in the emergency room. So a lot of times when they get up to the rooms, if you guys are working in the hospital setting, your patients are going to say, what? Why are you giving me insulin? I don't take insulin. Well, this is why, because we can't cover you with your oral hypoglycemics. So you just want to make sure you're educating your patients. So insulin is a hormone that promotes the storage of the body's fuels. It facilitates the transport of various metabolites and ions across various cell membranes. It stimulates the synthesis of glycogen from glucose, and it reacts with specific receptor sites on the cells. So we use this to treat type 1 diabetes and type 2 diabetes in patients whose diabetes cannot be controlled by diet or other agents. There's a lot of different insulins out there. The peak, the onset, and the duration are going to vary depending on the preparation. Some of them work very quick and they don't last very long. Some we take at night because they last all night long. There's a lot of different ones, and we're going to learn more about them next semester. Pregnancy, you just want to use cautiously in patients who are pregnant and lactating. The adverse effects, so sometimes we could cause hyperglycemia if we don't give enough. Sometimes we can cause hypoglycemia if we give too much. And then sometimes ketoacidosis. So you would want to be careful when you administer this medication with any other drug that decreases glucose levels. And then you want to use cautiously with beta blockers because they can decrease. Remember we said a couple weeks ago when we talked about the SNS system that sometimes it blocks many signs of symptoms of patients that have that are suffering with signs of hypoglycemia, that they don't recognize the signs and symptoms like they normally would if they're on a beta blocker. So that's why you just want to be careful. They're going to have to learn other ways by checking their blood sugar more often and paying attention to other different symptoms that their body gives them. Okay, so what kind of diagnostic tests do? We can check our patient's blood sugar by doing a fasting glucose. This is where the patient comes in the morning, they don't have anything to eat or drink, and we test their blood sugar. Then we can do a glycosylated hemoglobin level. We call this an A1C. That's what we call it. We don't say this big word in the hospital setting, so you would just say an A1C. And what this does is it provides a three-month average of a patient's glucose levels. So if you had a patient that wasn't checking their blood sugar every day, you ask them, is their blood sugar well controlled? Well, I think I eat properly. I'm not really sure. I don't check it every day. This tells us if they've been compliant with their medication, their diets, and stuff like that. This is usually done in the primary care setting. We do it sometimes if we think that our patients are not complying with their medication regimen. We do it sometimes if they're diagnosed for the first time in the hospital. If they didn't know they had diabetes, we'll check it. Okay. So the A1C, that's going to give you a 3-month average of those glucose levels. And then it's good. Sometimes when I go to the primary care setting and I'm seeing patients, And I'll say to them, how have you been doing with your diabetes? Oh, I'm doing great. I'm exercising. I'm doing so good. And I'm like, okay, we're going to send you for labs. And then they come back and their A1C is like 10, which means they've been bad. They're eating lots of food. Ideally, depending upon their age and what other comorbidities they have, depends on where we want them. For the average person, we would like it to be under 6, closer to 5. Sometimes if they have a lot of cardiac issues and things like that, we want it to be between 6 and 7. It just depends. But you guys will know that more in next semester. I don't expect you to know that now. So we do treat diabetes with these sulfonylureas. So there are 2 generations of these medications. The first generation, we don't see as much. I still see some of them in my practice for NP because they work on these patients. There's sometimes you have patients who are very hard to manage, and these first generations sometimes work for them, but we don't use them anymore because they are associated with an increased risk of cardiovascular disease. So whenever you have a patient that has diabetes and you're giving them a medication, you always want them to have a cardioprotective medication because you want to give them some cardio protection because you don't want to cause any cardiac issues. They already have enough going on. So these second generations are going to be the ones that you see the most. So that's your glycoside, your glimepiride, your glipizide, and your glyburide. And again, you might not see a lot of these if you are in the hospital setting because we don't give these. And if you do, then it is probably a good idea for you to contact the doctor and say, hey, did you know this patient is still taking his oral hypoglycemic medication? Because then you're going to want to discontinue it. So the second generation, we said that they do offer that cardio protection. They also have a couple other advantages. So they are excreted in the urine and the bile. So that makes it safer for patients that suffer with renal dysfunction. Renal dysfunction and diabetes go hand in hand. We're going to talk about that more next semester, but all that glucose going through the blood causes your blood volume to thicken. It causes hypertension. So you're going to have high blood pressure. So if you have high blood pressure all the time, you're not going to get good blood flow to those kidneys, to your organs. So that's why you see this kidney dysfunction. That's why these patients end up on dialysis. So it is safer for patients with renal dysfunction. They don't interact with as many of the protein-bound drugs as those first generations do, and they have a longer duration of action. So it makes it possible for these patients to take it only once or twice a day, which is better because then it increases their compliance. So what do these medications do? So they stimulate insulin release from those beta cells in the pancreas, and they improve binding to those insulin receptors. We use these in combination with diet and exercise to lower blood glucose levels in type 2 diabetes. They are rapidly absorbed from the GI tract, and they undergo hepatic metabolism. They're excreted in the urine, and then their peak and their duration is going to vary with each drug. They're all very different. So you wouldn't want to use if you had an allergy to any of the combinations of these medications, if you've had diabetic complications, and then if you have type 1 diabetes. So this is not the only thing that type 1 diabetics can use is insulin. So adverse effects, well, we could cause hypoglycemia, right? If they don't take enough, it could cause increased levels of blood sugar, which would be hyperglycemia. These can cause some GI distress. Sometimes patients say that they get a little nauseous, that they get diarrhea. Usually I see that these things subside after they're on the medicine for a couple weeks. If they don't, you would have to change the medication. And then sometimes you have allergic skin reactions. You would want to use cautiously with other medications that acidify the urine. Be careful with those beta blockers because, again, people that take beta blockers and these medications, they don't get the symptoms of hypoglycemia. So normal people that have hypoglycemia, sometimes they can lose consciousness. They'll be shaky. They can be sweaty. They can be disoriented, nauseated. If you're on beta blockers, you don't get that normal, you don't get those symptoms, or they're not as severe. So it might not be as easy to notice. And then you would want to use cautiously in alcohol, with alcohol, because remember we said it undergoes hepatic metabolism, and then alcohol is hard on our liver. So then we have the non-sulfonylureas. So these are your glucophage, extended release, your glucophage, and your metformins. That metformin is pretty much the gold standard. The actions, indications, pharmacokinetics, these all vary depending on the medication. So we're not going to talk about, we're not going to go into detail about those. And then we know whenever we are treating someone in the hospital that has high glucose, we always run the risk of causing low glucose. So then we have to have things on board to treat that hypoglycemia pretty quickly. So usually if you have a patient that comes in as part of your order set in your MAR, which is your medication administration record, where all your medications are, you'll have your insulins, the schedules that you give them, your sliding scale, but then you'll also have under your PRN tab, these glucose elevating agents. The doctor usually decides which one. And actually they usually give, the one that I see most is the D50W or the dextrose. So those we give, some of them come in the form of an injection, but it takes too long. If you have a patient that has a blood sugar of 50 or 30, you're not going to give them an injection because it's going to take too long. You're either going to give them orange juice with sugar in it if they can take it. If they're coherent and they can swallow and they feel okay, you can give them orange juice or apple juice with sugar in it. If they're NPO and they can't have anything or they're not conscious, then that's when we would use these intravenous medications. So we usually give the dextrose or the D50W. It comes in a little bottle and you usually have to give them like sometimes 50 cc's of it. It's very thick. It's very hard to pull up. And then it's hard to push into the IV as well, but it works pretty quickly. Usually within 4 minutes when you recheck the blood sugar, their blood sugar is already up. So we use these medications here to increase the blood glucose levels by decreasing insulin release, and then it accelerates the breakdown of glycogen in the liver to help release that glucose. It's indicated for the treatment of hypoglycemia. It is rapidly absorbed and distributed throughout the body, and it is excreted in the urine. You wouldn't want to use if you had any known allergy. You just want to be careful in patients who are pregnant. And then cautiously, you want to use cautiously in patients with hepatic issues and cardiovascular disease. Sometimes it can cause GI upset. I've seen that once or twice probably. And then drug-to-drug interactions. So you would want to use this cautiously with any of your patients that are on thiazide diuretics, because the risk of toxicity can occur because the properties in these medications with the thiazide diuretic are very similar. So it can cause toxic levels. And then you also want to use cautiously if they're on an anticoagulant, because the effects of that medication can be increased. So these are the types of insulin. You have rapid acting. Novolog is the one that I see all the time in the clinical setting. You also have Humalog, Apidra. The rapid acting is going to take 10 to 30 minutes before it reaches the bloodstream. It's going to peak. So that is the time, remember, when the insulin is most effective. It's going to peak 30 minutes to 3 hours, and then it's going to last for about 3 to 5 hours. So the Novolog, that the rapid acting, this is the one that we give 3 times. Well, we give it at breakfast, lunch, and dinner, and then we give it at bedtime. So 4 times a day, AC and HS. We have your short acting, which is your regular insulin. It works within 30 minutes to an hour. It peaks in 2 to 5 hours, and it works up to 12 hours. You have your intermediate acting, which is your NPH. Takes about 1.5 to 4 hours, peaks in 4 to 12, and it can last up to 24 hours. And then you have your long acting. So sometimes patients get this at bedtime. You have Lantus or Levemir. It takes 0.8 of an hour to 4 hours before it starts to work in the body. Has a very minimal peak. It has a more controlled distributing pattern, and it can stay, it can work for up to 24 hours. Okay. And that is it for the endocrine system. What questions do you guys have?
I have one on that last slide you were just on. Can you go back to it?
Yes.